breaking down the anatomy, we know that there are several steps involved here. One, we need to circumvent the perimeter of the hospital in order for us to actually be within the network to induce harm to the patient. Once we circumvent the perimeter, chances are we're going to compromise an externally facing system like a web server or some form of network equipment, maybe a firewall. Once we have that access, it's very good, but that's not the end game. We're going to have to kind of get to the patient. In order to do that, we're going to have to pivot through the network. And from there, compromise the end system, which would be a medical device, and we can do that in many ways, as I've demonstrated, and we profit. So, circumventing the perimeter. How do we do that? Well, as a remote attacker, we know that we want to attack Hospital A. We need to identify all of the external endpoints for Hospital A, and that's going to be your typical reconnaissance, information gathering, finding all the exposed systems and applications. As stated, this anatomy is going to exploit a web application, so we targeted the external web server and application that we identified. It happened to be a PHP application. Just because it was written in PHP doesn't mean that it's vulnerable. However, every time I see PHP code, I immediately think, oh my gosh, file inclusion, oh my gosh, SQL injection, win, win, win. So you always want to attack it. And sure enough, that application was vulnerable to inclusion attacks, SQL injection attacks, etc. So this is a pretty easy win for us. And then we identify and exploit vulnerabilities. Once that system is compromised, we're able to map the internal network, and then from there, hopefully exploit these newly identified systems. And we're going to map them using typical port scanning tools, Nmap, custom scripts, etc. And then compromising the end system. Basically, once we're on a network, we pivoted through, we identified medical devices and within a network segment that we needed to reach. Now we need to compromise them, and we're going to do so using some of the vulnerabilities that I talked about earlier in this talk, or by some other means, or through some other means. So here's the attack demo. It's not real world, it's an animation, but it will help articulate what I'm trying to say. So, could somebody kill a patient from another country? The answer is absolutely. And as I decided, or as I talked about, we compromised an internet-facing web server, specifically the application. From there, we were able to pivot within the network, and we gained access to an affected medical device, one of the devices that I had listed on my slides. And then from that medical device, we showed that we were able to induce harm. And we weren't able to directly induce harm as this image depicts, as again, these devices that we evaluated were passive, so it would take some, I guess, intervening force, such as a nurse, administering the wrong prescription dosage to, I guess, induce this harm or inflict this harm. But that isn't to say that the devices that we evaluated couldn't have been an active device, and then we therefore would be able to immediately, I guess, I don't know, I'll use an insulin pump as an example, give somebody an overdose of insulin. So from there we profit, we win. As the bad guy, we broke into the hospital, we gained unfettered access to your systems, and we potentially harmed one or more patients. This is disastrous, especially from a PR perspective. I mean, that's putting aside, the health of the individuals. So, attack anatomy number 2. This is kind of similar to what we had just talked about, except this one is called the hospital lobby kiosk attack. It's kind of funny, kind of cool, because we do exactly what we just talked about from inside the hospital. So it's kind of like we're there while it's happening, IT staff has no idea what's going on, and it's just win-win-win. So what we're going to do is crack the hospital from the inside. How are we going to do it? A computer that is accessible to us. No, there wasn't like a network jack that we were just able to plug into and had unfettered access, but there was something that was almost the equivalent of that, and that was the kiosk. So our vantage point in this time isn't remote, it's local, but arguably it's remote because anything that's accessible to users of, let's say, a lobby shouldn't be on your protected networks, right? You would think. Well, so what we're going to do here, again, is as an attacker, we need to circumvent the perimeter. You can think of the perimeter as kind of more of an abstract thing, like a network, for instance, as opposed to being like the front door of the hospital. Again, we'll have to pivot within the network once we compromise the device, and then we're going to look for an end system, i.e. a medical device, compromise it, and then profit. So, kiosk. Yes, this is a real picture with a real kiosk. This kiosk here resides in a lobby of one of the hospitals we evaluated. Anybody can walk in and leverage this kiosk to do whatever they want. The primary purpose is to print out visitor badges. So, what we're able to do is hop on to this kiosk. We're immediately given the hospital prompt to sign in, but this is known as kiosk mode. So we're quickly able to jailbreak out of it. And how we're able to do that was actually rather simple. It just required some creative thinking. So you have the system, it's in kiosk mode, you can't get to a desktop, a command prompt, or do anything funny. So you kind of start thinking about the technologies involved of how somebody may implement a system like that. A very common thing would be web technology. So it's like, okay, if they could possibly be using web technologies, what is their client? Well, the client turned out to be a web browser. So what were you able to do? You can still right-click, okay? Right-click, view page source. What happens? Oh man, a lovely, view source window pops up, that's available in your developer tools. Well, you go to the file menu, you click Save As, and your little Microsoft Windows Run box or Save box comes up. Something you guys may not know, that save box isn't just for you to provide input to save files. You can actually access arbitrary locations in the system. So what did we do? Within the save dialog, we navigated to cv.exe, hit enter, there's our command prompt. Command prompt opened up immediately. As you can see, there it is. And you can see the save dialog in the back there. So yeah, we effectively broke out of kiosk mode. Yes! Now what? Well, this machine, again, should have been isolated. It wasn't. We immediately had a domain user. We immediately found out that it was on a protected network segment. Not the network segment that we needed, but who cares? We're now within the network. We have a domain user that we can use to access other systems. So again, just a screenshot showing, hey, we're on the kiosk, and you can't really see it on the projector, but this arrow is pointing to a reflection of me, and it's just me with the visitor band on. And on the system, we had the ability to execute code. So what did? Downloaded some utilities, showing that we downloaded PuTTY here. It's an SSH client, and we're able to run it. So this machine is compromised. It's game over. I do want to note that at this time, we didn't have administrator access, but that was irrelevant. As this machine is our pip machine, we were able to execute code, and we were able to execute or access systems and networks that were protected. Administrator access to this machine wasn't a concern, because we could just pivot into the network, compromise the system with higher privileges, and then use that system as our primary point of entry. So it's win-win fun. Whoops. Okay, so again, like I said in the prior attack anatomy, once we broke in the perimeter, we need to compromise an end system. This end system is going to be additional vulnerable systems or medical device. It just depends on where we are in the network and what amount of effort it takes to get to a segment that contains one of these vulnerable devices. So compromise, identify devices. Again, here's a demo. This one is another scripted video. So could somebody kill a patient from the hospital lobby? Yes! As you can see here, we're demonstrating that we broke out of the kiosk mode, and we have a command prompt. And then from here, it's the standard attack methodology I've been talking about, pivoting to the network to find vulnerable systems, exploiting those systems to ultimately exploit a medical device to ultimately induce harm to a patient. In this particular example, one of these systems that we were able to access was a medicine dispensing cart or whatever, and that's what you see that barcode scanner there, meaning that we essentially would be able to manipulate the dosage of drugs being administered. That's very, very bad. Yeah. So attack anatomy number 2, profit. It's win. So we've broken into the hospital now in 2 different ways. One from a remote perspective, remote vantage point, which could be anywhere outside of the hospital, and another from a local, but yet again remote vantage point from within the hospital. Awesome. I love that one. makes me so happy. Okay, so the next anatomy we're going to talk about is social engineering. This is fundamentally different from the prior two attack anatomies, in that we are no longer trying to crack the perimeter, but we are trying to crack the healthcare practitioner. And how are we going to do that? By exploiting the human factor. And what is our vantage point? Who knows? We could be anywhere, to conduct various types of SE-based attacks. So really quick, social engineering, the definition is the use of deception to manipulate an individual into doing what you want. And hopefully that's going to give you a shell, because we all love shells. Social engineering attack steps. So what we had to do here is come up with a means of performing an SE-based attacks. And you could do a phishing campaign, you could do malicious USB devices, as well as other things. We chose to go the malicious USB route. So what you need to do here, prepare your encrypted USB sticks, you need to deliver those malware-based sticks, and you have to wait for infection. Hopefully it doesn't take too long, but who knows? And of course, profit. Everybody loves profiting. So we had to prepare our malicious sticks, USB sticks, and as you see here, this is one of the devices that we actually used. And they're USB rubber duckies, so they're HID devices, and we constructed the payload as well as various, we constructed the rubber ducky payload that included various payloads depending on what we were trying to do. So in this case of compromising devices, we were able to leverage PowerShell to then download and execute a file of our choosing, which means you plug in this device, it bypasses the auto run, it's HID, your system recognizes it as a keyboard, it starts typing in 1 million words a second, and the file is ultimately downloaded, executed, and we have access to your system. So it's less sophisticated, but it's still really cool. Yeah, so what we had to do is get these USB sticks into the hospital and put them in within locations that we felt were likely, that they were likely to be picked up by somebody and plugged in. So we dropped them all over the hospital. Public areas like the cafeteria, as well as nursing stations or any other area that we could get to. And now we have to keep waiting. And within 24 hours, we had our first fish, yes.
IT staff?
Actually, yeah, we had IT staff, we had healthcare practitioners, and we actually had hospital executives plug these in. So it was just pretty incredible. And yeah, a demo of the attack, another one of these scripted demos. So could a USB flash drive kill a patient? Yep. So we distributed infected USB drives, as you see here. Healthcare practitioner, in this example, is picking one up, plugging into the device, and we compromise the workstation using the payload that I described. And again, from here, we are free to pivot through the network. And we're going to do the same thing, find systems to exploit, to ultimately find the medical device, own it, to then own a patient.
Good.
So, what's going to happen now? Profit. 3 times the profit. Yeah, so that's a lot of fun. Okay, so examine security aspects. We're going to talk about the human factor now. And a couple of things that we're going to touch on are the social engineering experiment that we conducted, as well as the division of responsibilities within a hospital. So, I mentioned multiple payloads. One payload leveraged the downloading of a file to execute a compromised system. Another payload leveraged, again, PowerShell, but to gather information about the victim. So in order to do this, we do malicious flash drives, which again were HID, human interface devices. We leveraged a PowerShell payload, and then we needed a logging server. This logging server was a PHP web application that I wrote with a custom API, and it logged information about the victim. The IP address, the username, computer name, device ID. The device ID was just the number of flash drive, and then the date at which they plugged the device in. So here you can see rubber duckies. Here is, I guess, our rubber ducky payload. And what's really important here is this highlighted string. And essentially this string is part of the PowerShell payload that we leveraged. And all we're doing is instantiating an instance of the web client method, and then we're invoking the download string method of that object to download a file and write it to the file system. But in this case, we weren't doing that. We were just calling out to a web server, which is redacted, with the pieces of information that we wanted to gather. And when somebody plugged one of those devices in, it logged on our beautiful server. Here. Some of this information is redacted, but these are real-world results. The IPs, timestamps are accurate, and usernames, everything. So as you can see, some of the usernames that we had there were nurse staff, just a generic user for a given nursing workstation or nurse workstation, as well as some other goodies that I wish I could talk to you guys about, but I can't say them by name. So just remember, hospital executives, network and systems administrators. We say IT professionals. We're not talking help desk. We're talking like network engineers here, like very intellectual beings picking up these flash drives and unsuspectingly plugging it in to only realize that, hey, their network just got owned. Something that they've worked very hard to build and secure. Yeah, they just undermined all of that. And I like to make jokes, you know, because it's kind of funny, but it's really not. And it's like we need to increase awareness to prevent, you know, attacks like this from succeeding, because to a degree, they're fairly trivial. Like we're not having to deal with the manipulation of pointers and memory addresses, you know, or pointer arithmetic to, I don't know, exploit some form of memory corruption, whether it's abuse after free, stack-based buffer overflow, heap-based buffer overflow. We're prying on the innate nature of humans to trust people, and that's kind of like devilish, you know. Yeah, but good things can happen if you're a bad guy. So division of responsibilities. What I mean here is that within the hospital organization, there wasn't a clear demarcation point between help desk and systems engineers or network engineers. Meaning that while we were performing these assessments and meeting with hospital IT staff, we actually encountered disruption, because these engineers were, I guess these engineers were required to do your trivial help desk types of actions, I guess, such as password resets. So an individual could be reviewing, I don't know, firewall logs or whatever, and then all of a sudden they receive a phone call and they have to reset, you know, Larry's password. And that really isn't a good thing. If you're the individual responsible for reviewing, let's say, IDS or IPS logs, you know, or reviewing a SIM, you shouldn't be resetting passwords. So there's kind of like this, I guess, misunderstanding of what responsibilities fall on what type of IT staff. Let's see, examine security aspects, infrastructure, architecture, and design. So a couple things that we'll be discussing here is the use of outdated software, systems with known malware infections, missing and unenforced security policies, undocumented systems, and unregulated vendors. So the use of outdated software. While performing these assessments of hospitals, or healthcare facilities, rather, we identify systems that were running Windows XP or Server 2003 on servers, and then a lot of their servers, even if they were running a newer OS, were out of date. This is disastrous for many reasons. One, XP and 2003 are no longer supported, meaning security patches are non-existent for them, or any, I guess, the current security patches are non-existent for them. So those systems are essentially ripe for the taking. And then it's very similar to servers that are running newer operating systems, but are running, you know, outdated software. So this is really, really, really bad. And my next slide has nothing to do with healthcare security, but I just kind of wanted to point out the fact that other industries outside of healthcare have the same problem, and in some cases it may actually be worse. Like maybe an airline running Windows 98. Yeah, that's terrible. If that doesn't scare you, I don't know what will. You know what I mean? Like when I got on my plane and I saw that, I was just like, please don't die, please don't die, please don't die. Another thing that we examined or identified within a hospital are systems that are compromised by malware. So here you have Microsoft Security Essentials, I believe. This was running on a system, and you can see that there was actually some form of detection. It was some form of web-based exploit, and it identified these files as being the culprits. This was a pharmacy machine, by the way. So the machine handling all your prescriptions and whatnot, yeah, it has malware on it. It's not so good. We should probably fix that. Same machine, you can see they have these awesome executables, coupon printer service.exe, and there are multiple instances of this file running on the system, all sitting in a network socket. Man, these guys are active shoppers. Always looking for the best deals. So that's a serious problem. I mean, you have machines within the network that are compromised. Not only is the integrity of that machine compromised, you can essentially assume that the integrity of the entire network the entire network segment in which that device sits is also compromised. So the next thing we're going to talk about is the missing and unenforced security policy. I mentioned earlier the demarcation between help desk and network or system level engineers. I guess the requirement for an engineer to reset a password as opposed to a help desk support technician, whatever you want to call them, is the epitome of the lack of security or non-existent security policies. So what's important here is that a hospital actually has these defined policies that outline and clearly articulate what are the responsibilities of every individual within the IT organization, as well as providing adequate training for non-technical personnel. And that's where the secure computing comes into play. So all of this is exemplified by earlier topics of discussion. Again, the use of outdated software, the malware infections that we talked about, and then untrusted peripherals. We didn't talk about those. Yes, we did. People clicking up my flash drives and plugging them in. So undocumented systems. Hospitals have very poor inventory controls, as we learn. And specifically, the example that I'm referring to is we performed a nmap scan of the network. We came up with a list of devices, and we actually inquired about one of them to a support engineer. This individual had no idea what the system was. It just resides on the network. Furthermore, they had no idea where the system was located. So what did they start doing? Tracing Ethernet cables. They eventually found it, but that again right there just shows you that undocumented systems can run rampant on a network, and those administrators may have no idea that they exist.
What was it, a Novell server that runs forever?
No, if memory serves, it was an old Debian server. Yeah, I don't recall. Jake, do you recall what the operating system was? Yeah. So yes. Unregulated vendors. So something that's kind of interesting that may not be made, I guess, abundantly clear to really anybody. I mean, I had no idea about this. Is that in a lot of cases, hospitals act as an ISP in some capacity, meaning that different departments are sometimes third party or they aren't directly related to hospital personnel. An example would be the pharmacy. So we found that pharmacies, in a lot of cases, are networks, systems that weren't deployed or managed by hospital personnel. Essentially, the hospital IT staff set up a means for these third-party departments to plug in their systems and then access the network and resources. So vendors have the ability to deploy systems and software on various network segments. They have, I guess, a lot of control, and hospital IT staff has very little control. The vendors are dictating the configuration of these network segments, as well as the configuration of the devices, which again can poke holes in the overall architecture of the network. And overall, hospital staff takes a hands-off approach. The third-party vendor will provide the staff with a list of requirements for them to deploy their system, and the staff will then adhere to those requirements, and then they won't touch it ever again. So from there, once the system is deployed, let's say the pharmacy, going back to that example, they can start making changes to these configurations, adding new systems. the IT staff isn't going to have any idea. And by virtue of this, the IT staff is going to overlook a lot of security issues. An example that we found is some of these systems that were residing on network segments that weren't controlled by IT staff ran software like PC Anywhere, I think is one, or yeah, PC Anywhere is one. What's another big one? TeamViewer is another one. So these were essentially backdoors into a network. Again, were these put here by those third-party vendors or somebody who compromised those systems? Who knows? It's really hard to say. So what do we do about all of this? It's pretty bad. Outside of addressing the implementation level issues in the medical devices that I talked about earlier, like your typical how to address software-related bugs, the recommendations that I'm talking about here are kind of, I guess, they're broader. Meaning that emphasis needs to be put on securing the health of patients as opposed to compliance. And what I mean by compliance, EHR, electronic health records, right? Everybody's concerned with that today, is the protection of those systems. And while it is mission critical to protect health data, it's arguably more critical and important to protect the health of those patients. Because who cares if Joe Schmo's data gets out, if Joe Schmo is dead, right? I mean, obviously Joe Schmo wants to try and keep his information private, but the health and well-being of Joe Schmo is far more important than the releasing of his data. Hospital IT staff, they need to take the power back. Basically, there needs to be fine controls over how vendors are allowed to access hospital systems, and who is going to manage the systems once they're deployed. And threat modeling, this is very, very, very important. Basically, threat modeling is going to allow you to quantify the risk by identifying all of the assets, threat actors, and vulnerabilities that may exist within your infrastructure. So this is very important as you're going to remediate, identified issues. The order in which they're remediated is probably going to be contingent on your risk calculation. So threat modeling is very, very, very important. And then finally, FDA regulations are too strict. And what do I mean by that is all medical devices, as well as software, they have to go through this grueling certification process in which a certain set of requirements have to be met. Upon meeting them, their device will be certified, and then any further changes to the device require them to go back through that certification process. It's very similar to the FIPS testing and certification. So what happens, in a lot of cases, a device may be certified. Somebody may identify a vulnerability, or some deficiency within the system, and the manufacturer may not address it because it's going to require them to go back to that entire certification process, which could be awfully costly. Quite costly. And then finally, fines. If your device isn't compliant and something happens, you're going to be slapped with a very heavy fine. So again, this is deterring individuals from, patching their software or addressing any issues as they arise. So I feel that, I can't say this for certain, but I feel that if you were to disclose a vulnerability in a device, a manufacturer would try to the best of their ability to keep it on the down low, as opposed to publicly releasing the information to the public with an advisory and then addressing the issue. This is something that needs to change, and hopefully, in the coming weeks, months, hopefully not years, but I guess years, this actually happens. So that's my presentation. Yeah, that's it. Thank you. Thank you guys for coming.
Thank you.
And I guess we can open it up to questions. Does anybody have any questions? Yes.
How often do you find network ports with, they just give you DHCP access to a secure network?
So we definitely identified a couple of them. That wasn't the primary thing that we were looking for, and in one of the bigger hospitals that we looked at, they were less common than they were in some of the smaller hospitals that we looked at. So it's a hit or miss, maybe a 50-50 shot, but they normally exist. And if you don't have an open jack, we had found that there are systems, maybe like a kiosk that plug into a jack that you could probably just plug into and then gain network access. A lot of them weren't doing any type of device authentication, so you wouldn't be able to do that.
When you was at the kiosk, nobody.
Just doing device authentication, that would be the resolution for that type of attack.
Not entirely, as a lot of methods can be bypassed. For instance, people will attempt to authenticate devices on a network using MAC address filtering, and it's very easy to bypass. So it may deter less sophisticated attackers, but I wouldn't say that it's the solution to preventing the attack in general.
When you was at, yeah, you showed a picture of the kiosk,
Mhm.
and it looked like it was a very public area. No one, security didn't walk up to you and say, hey, why you got, windows, DOS windows popping up on your kiosk?
No, actually, so the kiosk screen face security, and while we're at the kiosk, right, they are oblivious to what's happening on the screen, and their day-to-day operation is, oh, I'm sitting here, I'm checking people to ensure that they have like these bracelets or identification badges. I know people are going to be using this kiosk. I only see people using the kiosk. Out of sight, out of mind. So, yeah, nobody bothered us. It was great.
Took 2 hours to print the visitor badge, but it worked.
Yeah, right? Yeah. Any other questions? No? Well, thank you guys again for coming. I really appreciate it. It's been an honor to speak here. So yeah, thank you.
Thanks.